This is Justine Sparrgrove, recording Chapter 17, Bipolar and Related Disorders. Let's talk about mood and affect. Mood is defined in the previous chapter as pervasive or universal and sustained emotion that may have a major influence on a person's perception of the world. Affect is described as an external observable emotion reaction associated with an experience. So sometimes we say people have a flat affect. That means they're not showing any of those emotions. They're not surprised, they're not sad. Everything's just kind of bland or plain. There's no emotions on someone's face. Mania. Mania is an exertion in mood that is expressed by feelings of elation, inflated self-esteem, grandiosity, hyperactivity, agitation, and accelerated thinking and speaking. Mania can occur as a biological or organic or psychological disorder or as a respondent to substance use or general medical condition. Epidemiology. Bipolar disorder affects approximately 5.7 million American adults, or about 2.6% of the U.S. populations ages 18 and older in a given year, and 82.9% of these cases are considered severe. The average age of onset for bipolar disorder is 25 years of age, so it's usually in the 20s is when you see it crop up. And following the first manic episode, the disorder tends to be recurrent, so it doesn't usually go away. Bipolar disorder is the sixth leading cause of disability in the middle-aged group, but for those who respond to lithium treatment, bipolar disorder is completely treatable with no further episodes. A bipolar disorder is characterized by mood swings from profound depression to extreme euphoria or mania. During a manic episode, the mood is elevated, expansive, or irritable. The disturbance is sufficiently severe to cause marked impairment in occupational function or in usual social activities or relationships with others, or to require hospitalization to prevent harm to self or others. The diagnostic picture for depression associated with bipolar disorder is similar to major depressive disorder, but the client must have a history of one or more manic episodes. Different type of bipolar disorders. So bipolar 1 disorder is the diagnosis given to a client who is currently experiencing a manic episode or has a history of one or more manic episodes. This diagnosis is further specified by the current or most recent behavioral episode experienced. The specifier might be a single manic episode or current episode manic, hypomanic, mixed, or depressed. Psychotic or canatotic features may also be present at this time. Bipolar 2 disorder is characterized by recurrent bouts of major depression with the episodic occurrence of hypomania. The individual may present with symptoms of depression or hypomania. The client has never experienced a full manic episode. The diagnosis may specify whether the current or most recent episode is hypomanic, depressed, or with mixed features. If the current syndrome is major depressive episode, psychotic or canatonic features may be present. Cyclorhythmic disorder is a chronic mood disturbance of at least 2 years involving numerous periods of elevated mood that do not meet the criteria for a hypomanic episode and numerous periods of depressed mood of insufficient severity or duration to meet the criteria for major depressive episode. The individual is never without the symptoms for more than 2 months. Substance-induced bipolar disorders. So disturbance of mood can be a direct result of physiological effects of substance. The mood disturbance may involve elevated, expansive, or irritable mood with inflated self-esteem, decreased need for sleep, and distractibility. The disorder causes distress or impairment in social, occupational, or other areas of functioning. Mood disturbances are associated with intoxication from substances such as alcohol, amphetamines, cocaine, hallucinogens, inhalants, opioids, phenylcyclidine, sedatives, hypnotics, and anxiolytics. Symptoms can also occur during withdrawal from substance use, such as alcohol, amphetamines, cocaine, sedatives, hypnotics, and anxiolytics. A number of medications have also been known to evoke mood symptoms, including anesthetics, analgesics, anticholinergics, anticonvulsants, antihypertensives, anti-Parkinson's agents, anti-ulcer agents, cardiac medications, oral contraceptives, psychotropic medications, muscle relaxants, steroids, and sulfonamides. Other medical conditions can also cause abnormally and persistent elevated, expansive, or irritable mood and excessive activity or energy. These disturbances cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So right away, let's check your understanding. A suicidal client with a history of manic behavior is admitted to the emergency department. The client's diagnosis is documented as bipolar 1 disorder. Current episode, depressed. What is the rationale for this diagnosis instead of a diagnosis of major depressive disorder? So the physician does not believe that the client is suffering from major depression. The client has experienced a manic episode in the past. The client does not exhibit psychotic symptoms, or there is no history of major depression in the client's family. So the correct answer here is B. The client's past history of mania and current suicide attempts support the episode rules out the diagnosis of major depressive disorder. The exact etiology of bipolar disorder has yet to be determined. Scientific evidence supports a chemical imbalance in the brain. Theories that consider a combination of hereditary factors and environmental triggers seem to be the most credible. So let's talk about biological theories of the causes of bipolar disorders. Research suggests that bipolar disorder strongly reflects an underlying genetic vulnerability. Evidence from family, twin, and adoption studies exists to support this observation. The twin studies have indicated a concordance rate for bipolar disorders among identical twins at 60 to 80% compared to 10 to 20% in fraternal twins. Family studies have shown that if one parent has a mood disorder, the risk that that child will have a mood disorder is between 10 to 25%. And if both parents have the disorder, the risk is 2 to 3 times as high. Ongoing genetic research will continue to shed light on the genetic influences in the development of bipolar disorder and the genetic factors that influence the response to treatments. Physiological influences of bipolar disorders. So neuroanatomical changes have been correlated with dysfunction in the prefrontal cortex, basal ganglia, and temporal and frontal lobes of the forebrain, and to parts of the limbic system, including the amygdala, thalamus, and striatum. The different symptoms in bipolar disorders may be correlated to those specific areas of dysfunction. Certain medications used to treat somatic illnesses have been known to trigger a manic episode. The most common of these are the steroids frequently used to treat chronic illnesses such as multiple sclerosis and systemic lupus erythematosus, or SLE. Amphetamines, antidepressants, and high doses of anticonvulsants and narcotics also have the potential for initiating a manic episode. Next, psychosocial theories of the causes of bipolar disorders. So psychosocial theories of the causes of bipolar disorders have declined in recent years. Conditions such as schizophrenia and bipolar disorders are more common, often viewed as disease of the brain with biological etiologies. The etiology of these illnesses remain unclear. However, it is important that both biological and psychosocial factors may be influential. The impact of bipolar disorders in childhood and adolescent development. So in the past decade, diagnosis of bipolar 1 disorder in children and adolescents has rapidly increased to 40 times what it has been historically. It was thought that there was a connection between ADHD and the development of bipolar disorder in youth, but research hasn't supported this. Studies also found that youth who were given this diagnosis more often manifested with a host of atypical symptoms, including non-discrete mood episodes, chronic irritability, and temper tantrums. A study of children with non-episodic irritability found that while these children had a higher risk for anxiety and depression, they were not typically at higher risk for developing bipolar disorder. Monotherapy with traditional mood stabilizers or atypical antipsychotics has historically been the first-line treatment for children. Augmentation with a second medication is indicated when monotherapy fails. Bipolar disorder in children and adolescents appears to be a chronic condition with a high risk of relapse. So maintenance therapy incorporates the same medication used to treat acute symptoms, although a few research studies exist that deal with long-term maintenance of bipolar disorders in children. ADHD has been identified as the most common comorbid condition in children and adolescents with bipolar disorder. Because stimulants can exacerbate mania, it is suggested that medication for ADHD be initiated only after bipolar symptoms have been controlled with a mood-stabilizing agent. Non-stimulant medications indicated for ADHD may also induce switches to mania or hypomania. Family dynamics and attitudes can play a crucial role in the outcome of a client's recovery. So interventions with family members must include education that promotes the understanding that at least part of the client's negative behaviors are attributed to an illness and must be managed. Studies show that family-focused psychoeducational treatment, or FTT, is an effective method of reducing relapses and increasing medication adherence in bipolar clients. This is important for adult clients as well as for children and adolescents with bipolar disorder. FTT includes sessions that deal with psychoeducation about bipolar disorder, communication training, and problem-solving skills training. Symptoms of manic states can be described according to 3 stages: hypomania, acute mania, and delirious mania. Symptoms of stage 1, hypomania. At this stage, the disturbance is not sufficiently severe to cause marked impairments in social or occupational functioning. The mood of a hypomanic person is cheerful and expansive. There's an underlying irritability that surfaces rapidly when the person's wishes and desires go unfulfilled. Perceptions of the self-induced includes ideas of great worth and ability. Thinking is flighty with rapid flow of ideas. Perception of environment is heightened, but the individual is so easily distracted by irrelevant stimuli, and goal-directed activities are actually difficult. Hypomanic individuals exhibit increased motor activity. They are perceived as being very extroverted and sociable, but they lack the depth of personality and warmth to formulate those close friendships. They talk and laugh a great deal, usually very loud and often inappropriately. I used to have a friend that had this all the time, and back in high school, we knew about bipolar but really didn't understand it, and she would laugh really loud, and it's kind of like it would be not at the right moments. You'd say, "My grandmother died," and she'd just go off laughing. So the stuff is really kind of exaggerated. You kind of look and go, what is kind of wrong with that person? Is really what you're thinking, even though you're going, okay, there's something, going on, but you're not really sure what quite it is. But it's a great thing. If you ever see someone with it, then you'll never forget that that's really what it's talking about. All right, so stage 2, hypomania. Symptoms of acute mania are a progression in intensification of those experienced in hypomania. Most individuals experience marked impairment in functioning and require hospitalization. Acute mania is characterized by euphoria and joy. The person appears to be in a continuous high, but mood is always subject to frequent variations. Cognition and perception become fragmented and often psychotic in acute mania. Accelerated thinking proceeds to racing thoughts, over connection of ideas, and rapid abrupt movement from one thought to another, and may be manifested by continuous flow of accelerated pressured speech to the point where they're trying to converse with this individual, maybe conversation, with this individual may be extremely difficult. Attention can be diverted by even the smallest amount of stimuli, so that squirrel moment. And then hallucinations and delusions are common. Psychomotor activity is excessive, sexual interest is increased, there's poor impulse control, low frustration tolerance, and the individual who is normally discreet may become socially and sexually uninhibited. Energy seems to be inexhaustible, and the need for sleep is diminished. They may go for many days without sleep and still not feel tired. Hygiene and grooming may be neglected, dress may be disorganized, flamboyant, or bizarre, and the use of excessive makeup or jewelry is common. Stage 3, the delirious mania. Delirious mania is a serious form of the disorder characterized by severe clouding of consciousness and an intensification of the symptoms associated with acute mania. The mood of the delirious person is very unstable. He or she may exhibit feelings of despair, quick converting to unrestrained happiness and ecstasy, or becoming irritable or totally indifferent to the environment. Cognition and perception are characterized by clouding of the consciousness with accompanying confusion, disorientation, and sometimes stupor. Other common manifestations include religion, delusion of majesty or persecution, and auditory or visual hallucinations. The individual is extremely distractible and incoherent. Psychomotor activity is frenzied and characterized by agitated, purposeless movements. The safety of this individual is at stake unless activity is reduced. So exhaustion, injury to self or others, and eventually death could occur without any intervention. All right, so nursing diagnosis. So one of them could be risk for injury related to extreme hyperactivity, increased agitation, and lack of control over purposeless and potentially injury movements. Another one could be risk for violence, self-directed or other-directed, related to manic excitement, delusional thinking, hallucinations, and impulsivity. Imbalanced nutrition, less than body requirements, related to refusal or inability to sit still long enough to eat, evidenced by loss of weight or amenorrhea for women. Disturbed thought processes related to biochemical alterations in the brain, evidenced by the delusions of splendor and persecution and inaccurate interpretation of the environment. Disturbed sensory perception related to biochemical alterations in the brain and by possible sleep deprivation, evidenced by auditory and visual hallucinations. Impaired social interaction related to egocentric and narcissistic behavior. And then insomnia related to excessive hyperactivity and agitation. I always want to think about when they go without sleep, think about how you feel when you try and sit for 24 hours or 48 hours, how you don't think properly, and that's without anybody who doesn't have an underlying disorder or bipolar feels on a day-to-day basis. But then imagine what someone that has a bipolar diagnosis feels when they go without sleep. All right, now let's check your understanding. In the initial stages of caring for a client experiencing an acute manic episode, what should the nurse consider to be the priority nursing diagnosis? Risk for injury related to excessive hyperactivity, disturbed sleep pattern related to manic hyperactivity, imbalanced nutrition, less than body requirements related to inadequate intake, or situational low self-esteem related to embarrassment secondary to high-risk behaviors. The correct answer here was A. According to Maslow's hierarchy of needs, Maintaining client safety is always priority. So always think safety. The impulsiveness and hyperactivity seen in the clients diagnosed with acute mania puts them at risk for injury. You never know what they're going to do. All right, so the following criteria may be used for measuring outcomes in the care of a client experiencing manic episodes. The client exhibits no evidence of physical injury, has not harmed self or others, is no longer exhibiting signs of physical agitation, eats a well-balanced diet with snacks to prevent weight loss and maintain nutritional status, verbalizes an accurate interpretation of the environment, verbalizes the hallucinatory activities as ceased, and demonstrates no outward behavior indicating hallucinations, accepts responsibility for own behaviors, does not manipulate others for gratification of own needs, interacts appropriately with others, is able to fall asleep within 30 minutes of retiring for the day, and is able to sleep 6 to 8 hours per night without any medications. For a diagnosis of risk for self or other directed violence, goals should include helping the client recognize signs of anxiety and agitation and preventing the client from harming themselves or others. Interventions include maintaining a low level of stimuli, like turning down the lights, no TV, music, anything like that, observing the client's behavior frequently, and intervening at the first sign of agitation or aggression. For impaired social interaction, goals should include helping the client verbalize inappropriate behaviors and helping the client demonstrate use of appropriate interaction skills as evidenced by lack of or marked decrease in manipulation of others to fulfill one's desires. Interventions include setting limits on manipulative behaviors and helping the client recognize that he or she must accept the consequences of their own behaviors. Imbalanced nutrition, less than body requirements. Goals should include helping the client consume foods to meet recommended daily allowances of nutrition and achieving 6 to 8 hours on uninterrupted sleep without medication. Interventions include assessing the client's activity level and monitoring the record of calorie intake and sleep patterns. All right, so topics for discussion with clients and family include the nature of the illness, including the cause of bipolar disorder and symptoms of depression and mania, management of the illness, including appropriate medication management, symptoms of lithium toxicity, and anger management, and support services, including crisis hotline and support group information. So it's really kind of giving them the whole picture of what's going on and what's going to happen. Also, we need to teach them about management of the illness, which includes the medication management, all about the medication, assertive techniques. So being able to be assertive with whoever it is that has the bipolar, and then the anger management as well. What is their role in that? Support services include that hotline, that crisis hotline, support groups, individual psychotherapy, and maybe sometimes legal and financial assistance because maybe they're behind on bills now because they're not able to hold down a job. Evaluation. So evaluation of the effectiveness of the nursing interventions is measured by fulfillment of the outcome criteria. All right, so treatment modalities for bipolar disorder. So therapy, whether in one-on-one environment or with a group, can be beneficial to a client suffering from bipolar disorder. Interpersonal and social rhythm therapy, or IPSRT, is a type of therapy specifically designed for bipolar patients. The focus of this therapy is helping clients to regulate their social rhythms or daily activities such as the sleep-wake cycle and exercise routines that may otherwise disrupt underlying biologic rhythms and contribute to the mood disturbances. So once an acute phase of illness is past, groups can provide an atmosphere in which individuals may discuss issues in their lives that cause, maintain, or arise out of having a serious affective disorder. The elements of peer support may provide a feeling of security as troublesome or embarrassing issues are discussed and resolved. In cognitive therapy, the individual is taught to control the thought distortions that are considered to be a factor in the development and maintenance mood disorders. The general goals in cognitive therapy are to obtain symptom relief as quickly as possible, to assist the client in identifying dysfunctional patterns of thinking and behaving, and to guide the client to evidence and logic that effectively tests the validity of that dysfunctional thinking. The recovery model. The recovery model has been used primarily in caring for individuals with serious mental illnesses such as schizophrenia and bipolar disorder, but the concepts of the model are amendable to use with all individuals experiencing emotional conditions with which they require assistance and who have a desire to control and manage their lives more independently. In bipolar disorder, recovery is a continuous process. The individual identifies goals based on personal values or what he or she defines as giving meaning and purpose to life. The clinician and client work together to develop a treatment plan that is aligned with the goals set forth by the client. So again, it's very important that you don't just make those goals for them, that they be involved, because sometimes as healthcare providers, we don't have realistic goals for what our patients can do. So it's very important to keep them in the loop. The recovery model continued. Although there is no cure for bipolar disorder, recovery is possible in the sense of learning to prevent and minimize symptoms and to successfully cope with the effects of the illness on mood, career, and social life. Episodes of acute mania are occasionally treated with electroconvulsive therapy, particularly when the client does not tolerate or fails to respond to lithium or other drug treatments, or when life is threatened by dangerous behavior or exhaustion. For many years, the drug of choice for treatment and management of bipolar mania was lithium carbonate. However, in recent years, a number of investigators and clinicians in practice have achieved satisfactory results with several other medications, including anticonvulsant drugs, which have mood stabilizing effects either alone or in combination with lithium. Clients who respond to lithium can virtually be symptom free over the long term, and about 33% of people treated with lithium respond positively. All right, so education with client family about lithium. When taking lithium, the client should continue taking the medication on a regular basis, even when feeling well. The client should not drive or operate dangerous machinery until lithium levels are stabilized. Notify the physician if vomiting or diarrhea occurs, and carry a card or identification noting that he or she is taking lithium. Be aware of the side effects and symptoms associated with toxicity. Notify the physician if any of the following symptoms occur: persistent nausea and vomiting, severe diarrhea, ataxia, blurred vision, tinnitus, excessive output of urine, increased tremors, or mental confusion. When taking anticonvulsants, the client should refrain from discontinuing the drug abruptly. Report the following symptoms to the physician immediately: skin rash, unusual bleeding, spontaneous bruising, sore throat, fever, malaise, dark urine, and yellow skin or eyes. Avoid consuming alcoholic beverages and non-prescription medications without the approval of a physician. When using a calcium channel blocker, such as verapamil, the client should take medications with meal if gastrointestinal upset occurs. Use caution when driving or when operating dangerous machinery. Dizziness, drowsiness, and blurred vision can occur. Report occurrence of any of the following symptoms to the physician immediately: irregular heartbeat, shortness of breath, swelling of the hands and feet, pronounced dizziness, chest pain, from mood swings, or severe and persistent headaches. When using antipsychotics, the client should use caution when driving or operating dangerous machinery again. Refrain from discontinuing the drug abruptly after long-term use. Use sunblock lotion, and wear protective clothing when spending time outdoors. Skin is usually more susceptible to sunburn, which can occur in as little as 30 minutes. Consult a physician regarding smoking while on antipsychotic therapy. Smoking actually increases the metabolism of these drugs, requiring an adjustment in the dosage to achieve therapeutic effects. And avoid drinking alcohol when on an antipsychotic therapy. These drugs potentiate each other's effects. Report the occurrence of any of the following symptoms to the physician immediately: sore throat, fever, malaise, unusual bleeding, easy bruising, persistent nausea and vomiting, severe headache, rapid heart rate, difficulty urinating, muscle twitching, tremors, dark-colored urine, excessive urination, excessive thirst, excessive hunger, weakness, pale stools, yellow skin or eyes, muscular incoordination, or a skin rash. So let's check your understanding again. A client who's prescribed lithium carbonate is being discharged from the inpatient care. Which medication information should the nurse teach this client? Do not skimp on dietary sodium intake. Have serum lithium levels checked every 6 months. Limit fluid intake to 1,000 milliliters of fluid per day, or adjust the dose if you feel out of control. Correct answer here was A. Clients taking lithium should consume a diet adequate in sodium and drink 2,500 to 3,000 milliliters of fluid per day. Lithium is a salt and competes in the body with sodium. If sodium is lost, the body will retain the lithium with resulting toxicity. Maintaining normal sodium and fluid levels is critical to maintaining therapeutic levels of lithium and preventing toxicity. And that is the PowerPoint slide.